Okay, thank you very much, and thank you for coming. Um, when I say what exactly is long COVID, you'll realize at the end that there is no exact to it, and that's precisely a large part of the problem. I'm just going to give a brief outline of what I'm going to talk about. I'll refer briefly to the course of acute COVID-19, and I hope you'll indulge me and excuse me for taking the opportunity to give you what I'm sure would be as a reminder of the immune response to viruses, because it's a very important part of the story. And similarly, to explain why the outcome of an infection can differ so much between different people. I'll say a word about vaccines, again, partly to correct what I think is some common misconceptions about antiviral vaccines. And then I'll come on to long COVID. Just before I start, I did a literature search yesterday. The number of papers published this year alone, not including papers that include the phrase post-viral fatigue or other more vague phrase, but the exact phrase long COVID. More than 1,000 papers have been published so far this year. I'm not going to pretend that I'm going to summarize or review all of them for you, so I apologize for that. I'll try and make a digest of some of what I hope are the more useful and important ones. So just to, as I say, remind you about the course of a typical acute viral infection. The course of the virus is shown in blue. That's the titer of virus. And then the innate immune response comes on first and is dominated, in the case of the antiviral innate immune response, by the interferons. And then the cellular aspect comes in a bit later, natural killer cells. The innate immune response, of course, is not specific to one virus. It's activated by any virus, and it has, therefore, strong advantages. And the acquired immune response gets going just a couple of days later. And the first aspect, the first element to appear is the cytotoxic T lymphocyte. These CTL, cytotoxic T lymphocytes, are essential to get rid of a virus from the body. If you don't have them, you develop a persistent infection. And then antibody in the primary immune response comes on just a couple of days later. As I emphasize, this is a primary, the first infection. So the importance of the innate immune system is that it destroys any invading nucleic acid, any foreign nucleic acid or DNA or RNA, including that, of course, of the viral genomes. It activates various inflammatory elements like the inflammatory interleukins. And importantly, it elicits the interferons, which initiate a very broad antiviral immune response. And the reason that it's so important is that the acquired immune response requires clonal selection to grow up the clones of B cell and T cell that are specific to that new virus. And that takes a few days for the clones to grow up. And so in the meantime, the innate immune system is already active, and it will buy time, as I put it, while the acquired immune response gets going. And it also plays an active part in starting the acquired immune response. But an important feature of the COVID-19 virus, SARS-CoV-2, is that it actually encodes a couple of genes that inhibit the interferon response. And it's one of the reasons that it has caused a particular problem, not the only reason, but one of them. So regarding the course of acute COVID, the way to think of it, I think, is in two phases. In the first week, it is growth of the virus. And in the second week, it's an inflammatory response. So in the first, the green curve, I'm sorry, the pointer doesn't work. The the green curve at first shows the growth of the viral genome, and then the actual viral titer is shown in the purple curve later. As you know, most people, fortunately, infected with the virus it will last for 10 or 14 days, and then they clear it, and they may feel a little tired for a few days afterwards, but most make a good recovery. In a small proportion, of course, it persists, and that's what we shall come on to. So you need to remember that the viral load, as in many, many viral infections, the key to the severity of the disease is the amount of virus you end up with, the viral load. So because of this two phases, which I should say is exactly the same, exactly analogous in SARS-1 from 20 years ago, is also biphasic. So the first week was presented like an ordinary respiratory infection, milder in the case of SARS-CoV-2, and the second week, an inflammatory response when it can turn severe. So because of that two phases, antiviral drugs can be of benefit in treatment and for the first week or 10 days, but after that, they don't really contribute. And after that, as of course was a major contribution was made by Peter Horby and colleagues, in finding that steroids have a major beneficial effect, in other words, anti-inflammatory. So it's this biphasic course that's typical of acute COVID. I said I'd say a word about why some people get so badly affected by any virus infection, not only SARS-CoV-2, but any virus, and others don't. The biggest single reason is because, of course, we differ enormously in our genotype, our genetics, and by far the most variable gene system we have is the HLA system, the tissue type. And the reason for that is that it's the HLA molecules that present the antigens to the immune system. So they are what's required to bind the antigen from a virus and stimulate the immune response. So this shows the cytotoxic T cells, which present by HLA class 1, so HLA A, B, and C, and the helper T cells are essential for the cytotoxic T cell response and the antibody response, and particularly important for the memory antibody response and indeed memory T cell response. And the helper T cells use HLA class 2. And as I mentioned, this HLA system is by far the most variable genetic system that we have. And this is a very direct consequence of the fact that infection is the biggest single category of selection force that has acted in our evolution. And the reason we are here is because our ancestors have evolved with a variety, a range of different HLA genes, and that was able to give them protection against a range of different pathogens. So it's a continuous evolution. It is, of course, continuing today, although, and some people have postulated it may be possible to see evolution in action with some infections such as HIV. So this just shows some of the dominant antigens in different parts of the world and emphasizing how variable they are. HLA-B, one of the gene loci in class 1 HLA, HLA-B has more than 200 variant antigens around the world. It is enormously variable. A very brief word about antiviral vaccines. People often talk about sterilizing immunity and preventing infection. In my view, antiviral vaccines do not prevent infection. If you can sometimes contrive it in a laboratory, in an experiment, but even that is very difficult. And this is shown, this is demonstrated by the fact that if you are vaccinated and you subsequently get a virus, if it's asymptomatic, even if it's asymptomatic, you can always detect a blip, a stimulus in the antibody response and the T cell response to that virus. And that shows that the virus has got in. In other words, the infection has not been prevented. So the purpose of antiviral vaccines is not to provide a complete block to infection. It's to attenuate the infection, with any luck to make it completely asymptomatic, and thereby to reduce the illness and also transmission, reduce the onward transmission to other people. So antiviral vaccines act by inducing both antibodies and T cells. And again, antibodies kill the virus by several different mechanisms. Not only you hear all the discussion about neutralizing antibody, and that simply blocks the virus from being able to get into the cell, but is much more variety of mechanisms by which an antibody can kill a virus. And they are often essential for the action or the protective action of that antibody, including complement fixation and so on. Finally, people, again, often talking about correlates of immunity. And the main one that's been used is, of course, the neutralizing antibody titer. And it's quite a good correlate of immunity to SARS-CoV-2. But it does not imply that neutralizing antibody is either necessary or sufficient for actual protection. And in fact, it is probably not necessary or sufficient for protection. So it's used because it's a convenient laboratory test, which does correlate quite well, but it's important just to make that distinction. We were extraordinarily lucky with the COVID-19 vaccines. If you remember, the initial criterion for an acceptable COVID-19 vaccine was that it would provide at least 50% protection. In the event, all three of the most widely distributed vaccines gave over 90% protection. And this was sheer good luck, actually. Not all viral vaccines are anything like so efficient. All of the COVID-19 virus, I'm blocking the way, but the COVID-19 vaccines all elicit immune response just to one of the viral antigens, which is the spike protein, the surface protein, which is the one that lets the virus into the cell. But the vaccine elicits not only antibodies, but T cells to that spike protein. And it's the T cells that are especially important in providing the cross-reactive immunity, the cross-protection against different variants. And the reason is that T cells recognize the parts of an antigen that antibodies often don't recognize. They recognize the internal determinants. And they also recognize other proteins of the virus. And so if you have had the infection with SARS-CoV-2, you'll make an antibody response and a T cell response to many of the viral proteins, not only the spike protein, and they will all contribute to protection. And that's, of course, largely why you get a better measure of protection against reinfection from having had the infection than from the vaccine. So T cells are very important for cross-variant protection. So it follows that an ideal vaccine would include not only the spike protein, but some of the other antigens from the inside of the virus, which the T cells can also recognize. But of course, the barrier to developing these is huge because the existing ones are so effective that it's not worthwhile any pharmaceutical company investing in developing and producing a new one. However, some other approaches are being taken, and I'm just illustrating one that's very recently published here in a collaboration actually between colleagues here in Oxford, Alan Townsend and people in the US. And what they've done is to make a little molecular, what they call nano cage. And they've decorated it with the receptor binding proteins from different variants of SARS-CoV-2. So this is another approach to developing the broader antigenic specificity, the broader protection against different variants of the virus. This has only just been published. It's undergoing trials at the moment. I'm not sure whether it's going to find a foothold in the anti-COVID protection. So to come to long COVID, the definition of long COVID varies widely between different groups. And I'm just illustrating two of the most prominent and most widely used, the WHO definition and the NICE definition. So the WHO definition, as you see, defines it as COVID-like symptoms that can't otherwise be explained, that carry on, that usually start within 3 months and last for at least 2 months. The time definition is slightly different from the NICE case definition, but they're already indicating that it overlaps with other syndromes, in particular post-viral fatigue, post-ICU syndrome, and so on. This was unfortunately representative of emails that I occasionally get. I received this about 4 days ago from someone I've never met, and it just emphasizes the degree to which some families are affected. This person's brother and his partner have been completely knocked out for more than a year and are unable to function. And in replying, I had to make it clear, I'll come to at the end, that there is no therapy that has proved benefit. But I was able to end on a more positive note, which was that I was told last week of actually Alan Townsend's nephew, who had previously been undertaking, he'd been doing Ironman competitions, ridiculously competitive physical competitions, who then got long COVID and for a year was almost unable to walk, could walk hardly any distance. He's now recovered and he's back doing Ironman competitions. So I think there is hope, and I wanted to end on a positive note, but it is very difficult. I also cautioned them against, I said, I suggest you should be careful about investing large sums of money in potentially expensive therapies where the benefit is far from clear. So the symptoms of long COVID have been defined by a number of groups, but of course the list gets longer and longer. This was the list developed by the Recover cohort during the pandemic. They identified 37 main symptoms in different organs and different systems, physiological systems, but a total of many, many more symptoms have been associated with this syndrome. So the definition is in danger of getting broader and broader. The commonest symptoms you'll be very familiar with. Loss of alteration or loss of smell and taste is one of the slightly more specific symptoms associated with COVID and indeed long COVID. Otherwise, it's the post-exertional malaise and tiredness, the brain fog, and the chronic cough, which are by far the most common. But in addition, there are some clearly defined other syndromes, such as the postural orthostatic tachycardia syndrome, which require, of course, very different types of therapy. The big epidemiological challenge is precisely that it's so broad. The signs and symptoms of long COVID vary enormously between people and within one person, very often over time. So the same person can develop very often brain fog or one that is persistent, but sometimes they'll have chest pain associated with myocarditis, and then breathlessness the next week, and then headache and so on. It can change over time in one person. So the course it can be very unpredictable, with rapid fluctuations in the severity and, as I say, the type of the symptoms. And as I've already mentioned, the signs and symptoms are very non-specific. So the case definition is extraordinarily difficult. And I've been discussing this with my colleague in Imperial, Paul Elliott, who is the person who led the very large REACT cohort study during COVID. And he's now switched it to following long COVID in order to follow the epidemiology of the condition. So how frequent is it? Well, The prevalence, again, estimates vary widely, partly because the definition is so variable and broad. But I think it's fair to say that recent estimates are converging to around 8% to 12% of those who are infected at 3 months. Of course, this changes over time. And the prevalence is significantly higher in women, and some relative risk estimates are quite high, 4-fold higher in women than in men. Not all of that high, but it's usually between 2- and 3-fold higher. Of course, those with a pre-existing health condition, particularly respiratory or cardiac or renal conditions, or highest degrees of social deprivation. And as you'll see later, those infected with the original so-called Wuhan variant, when that was dominant. There's also a significantly lower prevalence in those who are infected after the Omicron variant became dominant. And so if you put these together, a very conservative estimate of the number around the world is around 65 million. But in fact, the real number may be significantly greater than that. Now, over the course of the pandemic and afterwards, I've had regular discussions with colleagues who it's very common for them to say, long COVID is a collection of different syndromes, it's variable. And I've said, well, clinically, there's no doubt it does present in very different ways, but surely to understand the condition, we should start from the hypothesis, applying Occam's razor, that underlying the causative mechanism of the condition is either one or a small number of pathways. And those are what we should be looking for. It's not to deny the variety of the clinical presentation, which is all too evident, but rather to say we must be looking for one or a small number of pathogenetic mechanisms that underlie it. So what are the hypotheses that underlie this? Well, again, a very wide variety of suggestions have been made. It's commonly said in the early days that there was an excessive immune response to the virus. In my view, there was never any evidence for this, and I would strongly resist this. All the evidence, in fact, from quite an early stage was that a strong immune response to the virus was a good thing, not a bad thing, particularly during the first week, which is when the virus is trying to replicate. Again, it's been commonly suggested that the virus is somehow eliciting an autoimmune reaction. Essentially, I think there is no good evidence for this, so I would dismiss this for the time being. We have to reserve judgment, but at the moment, there's no good evidence. There have been more non-specific suggestions about so-called metabolic disturbance, which is a rather vague term, or oxidative stress. And there are indications that this happens, but whether that's the fundamental root of the problem is another question. I'll come on in a moment to say that people have suggested that reactivation of latent or chronic herpes virus infections, notably Epstein-Barr and varicella zoster viruses, might contribute. That remains an open question. We'll come on to that in a moment. And I think the much more attention has been and should be developed, focused on a chronic inflammatory response in the aftermath of the infection. So what about actual evidence? Well, I'm pleased to say that during the last year, 18 months, what I regard as some really important findings have been made. And I think we're just beginning to get one or two handles on the pathogenesis of this awful condition. So first, abnormalities have been found in immunology and the immune response and in inflammation. It's found that people with long COVID have a higher count of B cells, antibody-producing lymphocytes, in the circulation. They have a higher titer of antibody against the spike protein. They have chronic activation of the complement pathway by classical route. The classical route is usually antibody-mediated. and they often have higher concentration of certain chemokines and cytokines which contribute to inflammation. And a very remarkable finding was reported only about 6 months ago, which is that people with long COVID often have an abnormally low or a significantly lower concentration of cortisol in the serum. But interestingly, it's in the presence of a normal ACTH, suggesting that the hypothalamic pituitary axis is somehow blunted. And more recently, there's another anti-inflammatory response, which is typically triggered by the interleukin IL-2, interleukin 2, and that appears to be suppressed in people with long COVID. Finally, as you will know, a complication of acute COVID and of a rare complication of the vaccines is thrombosis, particularly in small vessels. And indeed, there are markers of chronic activation of thrombotic pathways and activation of platelets in people with long COVID and in the endothelial cells. And these authors found that if you use only serum concentration of cortisol, it accounts for by far the majority of cases of long COVID. So with an AUC, stands for area under the curve. It's the explanatory value of just that one laboratory measurement. So it seems that a major contributor to long COVID is that those people have an anomalously low concentration of cortisol. They seem to be failing to make the anti-inflammatory response that most people make. It's worthwhile pointing out that different inflammatory pathways do seem to be associated with particular symptoms. For example, certain pathways associated with myocarditis, some with other pathways, with other conditions. As regards abnormalities in the virus, again, some of these have been, I think, really very important. People with long COVID have higher concentration of antibodies against EBV and cytomegalovirus. And again, this suggests that those chronic viruses, which most of us have got, and they're mostly, in most of us, they're kept under constant control by our immune response. The antibodies of those are higher in people with long COVID. And what that strongly suggests is that those viruses have been reactivated. But whether that is cause or effect of the syndrome is quite an open question. It's simply not clear. In my view, it's more likely to be an effect than a cause. It might contribute, but it's more likely to be a side effect. I think one of the most important findings that's been made, which was there started to be hints of this quite early on in the pandemic, and I think the evidence has grown strongly, is this, that some of the proteins and the nucleic acid of the virus are not cleared from the body in people with long COVID. They persist long term. Now, normally, most of us, if we get acute COVID, we would expect to clear the virus and all traces of the virus from the body. Maybe it might take 2 or 3 weeks for the traces to be cleared, but the proteins and the nucleic acid ought to be cleared from the cells. But in some people, they persist. And I've just pointed out that in the previous slide, that people with long COVID have a higher concentration of antibody to the spike protein. And that is consistent with this observation, that the proteins seem to persist in a variety of organs in people with long COVID. It's important to distinguish this condition, long COVID, from a protracted infection, just an infection that in some people takes a bit longer to clear than others. It's a different condition. So up to about 0.5% of patients, of people infected with the virus, can develop slightly more protracted infections. And curiously, rather like Ebola virus, the virus can subsequently undergo rebounds in titer. But this is different from long COVID. And only a proportion of people, only something like 9% of people with this protracted infection actually report symptoms consistent with long COVID. So I just want to try and bring this recent evidence together on the pathogenesis. I think it's now clear that in some people, the proteins particularly, and maybe the RNA, the nucleic acid of the virus, fails to be cleared from the body. It may persist in different organs in different people, but I think it might be very important that it persists in the vascular endothelium. And in fact, I think that one of the reasons why the organs involved are so varied, and that therefore the symptoms and signs are so varied, is because if it involves the circulatory system, of course, it can involve any system in the body. And so I think that, in my view, it's very likely that this, which is undoubtedly happening, a major contributor may be the persistence of the antigen in the vascular endothelium. It's been shown in some people in post-mortem studies. I emphasize this is my hunch, and the evidence for persistence is strong. How much persistence in the vascular endothelium contributes remains to be confirmed. I've also made it clear that in people with long COVID, there appears to be suppression or failure to activate the normal anti-inflammatory response. Remember the low cortisol and the suppression of the IL-2 induced anti-inflammatory response. So that results in chronic inflammation with, as I mentioned, the complement activation, which is clear, and the microthrombi, which cause a lot of the problems. So putting these together, what I now believe is that if in those individuals who have an inefficient immune response, particularly early in the course of infection, during acute COVID, they fail to clear the virus and its proteins and nucleic acids completely from the tissues. And they set up this inflammatory response. Now, a degree of inflammation is a feature of almost all COVID infections, whether acute or chronic. But if the viral titer, the amount of virus is larger because the person has a less efficient immune response, the stimulus to the inflammatory response is greater. If that is combined with probably a genetic predisposition to make a less efficient anti-inflammatory response, then you end up with chronic inflammation and the symptoms of long COVID. It's just worth noting that other RNA viruses, it used to be the dogma that viruses with an RNA genome couldn't persist. But in fact, there's some precedent for this. It's been known for a long time that measles virus can persist, although this is usually in the central nervous system. And you may remember that in very rare instances, it gives rise to subacute sclerosing panencephalitis, a very rare late complication of measles. Ebola virus can also persist in some immunologically privileged sites like the eye, and again then can rebound. So it's not the first example of this, but it does seem to be more widely distributed than these other viruses. What can be done to prevent this? Well, what about vaccination? The evidence is quite clear on vaccination that if you're vaccinated before you get infected, you enjoy a good degree of protection against long COVID. It's not absolute, but it's there, and the evidence on that is really quite clear. If you're, it is very difficult to produce numbers on this, again, because of the heterogeneous definition and course of the condition. and because many of the studies done were frankly not good enough. But most of the studies did show an incident, a reduction in the incidence and in the severity of the symptoms who were vaccinated, as I say, before infection. In drug treatment during acute COVID-19, so the standard combination drug, one of the most widely used, Paxlovid, which is this combination shown at the bottom, doesn't seem to change the incidence of long COVID, but it makes some of the important symptoms, particularly the so-called brain fog, the cognitive symptoms, and the chronic fatigue, less severe. But again, remember, you have to intervene as early as possible, soon as possible during the acute infection to have a significant impact with antiviral drugs. What about treatment? Well, as regards vaccination, the evidence on this is conflicting, and I think it is really very far from certain. I'm very skeptical whether vaccination makes a good contribution. There have been anecdotal reports and some small studies which report an improvement in long COVID after vaccination of people who already have the condition. But some people report a worsening of symptoms after being vaccinated when they have long COVID. And so it's really not clear. It's quite different from the preventive effect of vaccination, which is clear. So because of the variety of symptoms, all that can, and the lack of understanding of the basic pathogenesis, all treatment essentially remains symptom specific. So for example, for the POTS syndrome, beta blockers, acquaintances on long-term steroid treatment for chronic myocarditis. It just depends on the major symptoms that person is suffering from. And many people, particularly in the early days, were advocating a very gradual, stepwise approach to exercise. In general, these have not been very successful. And generally, people start to get encouraged and then have to retreat and spend more days in bed because the fatigue is worsened. So again, it's very difficult to generalize, but there's been no very clear wide recommendations for graded exercise regimen. And because of the doubt of all of this and the uncertainty of how long it will last and the apparent inability to do much about it, psychological support is of great importance. Not least, I may say, because I still hear people ask, is it a real condition? I thought it's all psychological. Please counter that if you can. This is an extremely serious and very widespread, very common condition, which we desperately need to understand more about. Just to illustrate the lack of understanding, this is shown rather starkly by the enormous wide range of drugs that are being put forward for clinical trials in long COVID by the Recover initiative, including quite different categories of agent, antivirals, cardiac agents for some of the cardiac symptoms, and anti-inflammatories are better for some of the symptoms, and respiratory agents again, and some, well, you could see from the range, not only lithium and growth hormone, but steroids were one of the panaceas. But again, they can provide benefit in individual patients, but there's no way of generalizing how to recommend a regimen. So what's the outlook? In acute COVID, the median duration is about 10 days, just over a week. Of people who report continuing symptoms at 12 weeks, 31%, but only 31% had recovered after a year. And what this shows is that, as I mentioned earlier, the persistence of symptoms after the more recent Omicron variant and indeed Delta is significantly lower prevalence than than after the original Wuhan strain. The reason for this is that the selection in evolutionary terms, the evolutionary selection acting on the virus during the pandemic was mainly for rapid transmission. And if the virus is evolving to transmit rapidly, it doesn't mind so much, it doesn't make so much difference about the severity of the condition it causes. So it may sacrifice a bit in virulence just by chance. And because what is being selected for is the rapid transmissibility. And that is all to the good because, of course, the severity of the acute condition and the prevalence of long COVID were both significantly greater with the earlier variants. And just another thing from Paul Elliott's large cohort, excuse me, which I mentioned he's now studying long COVID. The curve to concentrate on is the gray curve, in which they have corrected for the other variants, the other variables that are correlated with severity, such as admission to hospital, length of hospital stay, and admission to ICU, and so on. So you can see that the cognitive symptoms last really quite a long time. The median duration is of the order of months. And again, many people have reported this. This is not in long COVID, but this is just over all of the patients. So it's been a bit of a whirlwind tour through the background to the immune response and vaccines and long COVID. I hope I've left you with some hope that we're beginning to get some glimmers of understanding of the mechanism of pathogenesis, which of course will be essential for being able to intervene in a more useful and decisive way. But the outlook for people who've got long COVID remains extremely uncertain, and we really desperately need more work to understand both the pathogenesis and the treatment. Thank you very much.